Hello, my name is Dr. Dan Lozier, and today we're going to be talking about the respiratory system. I'm really excited about the respiratory system, so what do you say? Let's get started. As always, we're going to start out with the anatomy and physiology. Very important that you understand both the anatomical structures in the respiratory system, but also their correlating physiologic functions. We'll divide the respiratory system up into the upper airway and the lower airway. You'll see that the upper airway begins at the nose and ends at the carina. Question might be you're asking, well, where is the carina? Well, the carina, if you bring your trachea and you have your cartilaginous rings on your trachea, at the bottom of the trachea, you're going to have the bifurcation of the right and the left main stem bronchi, the right and left main stem bronchi. Well, right here at the bifurcation of the right and left main stem bronchi is your carina. The carina is going to become important when we learn how to suction patients because we're going to introduce the suction catheter until we meet resistance. And then when we meet resistance, that's at the carina right here. If you're asking the question, just how far down is the carina? Well, usually the carina is right about at the position of our angle of Louis. You can see that the primary role and responsibility of the upper airway is defensive. It filters, warms, and humidifies the air. This is just another pictorial, a little more close up. The sinuses, even though there's a passage of airway, we really don't know any respiratory function related to the sinuses. We know that we use the sinuses for pronunciation of words for our phonetics. Another interesting anatomical structure here is called the epiglottis, and you're going to learn a little bit more about epiglottitis when we talk about pediatrics in another course section. The epiglottis is a thumb-like structure, and what the epiglottis does in response to the swallowing reflex, the epiglottis actually will close over and block over the airway. That way the food and the liquids will go down the esophagus and then not go down the trachea. And the trachea is this hollow tube, and it has these cartilaginous rings here, which give it some structure. All right, so let's see what the rest of the respiratory system looks like. So here's our carina. Here's our right and left main stem bronchi. And then the bronchi actually will subsegment into bronchioles. The bronchioles, you can see by the color change here, the bronchioles are encircled in smooth muscle. That allows bronchoconstriction and bronchodilation. The most distal section of the bronchioles are called the respiratory bronchioles, and then the most distal structures in the entire tracheobronchial tree are your alveoli. The alveoli is the primary place in the respiratory system where the gas exchange happens. Oxygen getting into the system and CO2 getting out of the system. So if you'd ask the question, wow, just how many alveoli are there in the human body? There are approximately 300 million alveoli in the body. So if you think of all these alveoli are participating in gas exchange, just how much surface area is that for gas exchange? Well, if we took the alveoli and we sliced them and we laid them flat, there's enough alveoli to cover the surface area of a tennis court. That is huge. That's a lot of surface area for participation in gas exchange. These last two structures here, the respiratory bronchioles and the alveoli, those are the only two anatomic structures in the entire tracheobronchial tree that participate in gas exchange. They actually have a term. The term is lung parenchyma. That's the term for the only two anatomical structures participating in gas exchange in the tracheobronchial tree. Not to be outdone, the remainder of the tracheobronchial tree that does not participate in gas exchange also has a name, and that's called the physiologic dead space. Now, where that's going to come into play is when we start talking about chronic diseases that, such as COPD, that destroy the alveoli. If you have destruction of alveoli from cigarette smoking over a prolonged number of years, as an example, These alveoli are no longer participating in gas exchange. So guess what you've just done? You have just increased the physiologic dead space, or those anatomic structures in the tracheobronchial tree that are not participating in gas exchange. These are the capillaries that are bringing CO2 to the alveoli to be exhaled out, and there's also the capillaries that are taking oxygen and bringing it to the cells of the body. This area here is on the outside of the alveoli. That's the semi-permeable membrane. That semi-permeable membrane um, is allows for diffusion of CO2 from the vasculature into the alveoli and oxygen from inside the alveoli to actually, by diffusion across the semi-permeable membrane, get into the vasculature and then to the cells and tissues of the body. The alveoli secrete and manufacture a substance called surfactant. That surfactant reduces the surface tension on the alveoli, so it prevents the alveoli on exhalation from collapsing. It keeps them open. And here's that pictorial on this side of the carina. Right and left main stem bronchi, your bronchioles, and then at the end of the bronchioles will be your alveoli. All right, here we're going to have a slide with some additional definitions that I think are important for you to recognize. The first one we'll talk about is apnea. Apnea is actually the cessation of breathing. Compliance is a term that we use for how much force is required in order to inflate the lungs. Obviously, the more diseased the lungs are, the more force is going to be necessary to inflate them. So a increase in requirement of force means that there's a decrease in compliance of the lung. Diffusion, we have talked about. Diffusion is the movement of molecules from an area of higher concentration to lower. Dyspnea, difficulty breathing. Hypoxemia is a decrease in the level of oxygen circulating in the bloodstream, and that can result in hypoxia, which is a decrease in oxygen to the cells and tissues, ultimately the organs of the body. The mediastinum is that area that is between the two lungs and contains these structures that you see listed here. Orthopnea is when you have difficulty breathing, when the patient goes from perhaps a sitting position to a lying position. Physiologic dead space we covered in a previous slide. Pulmonary edema. Pulmonary edema is the abnormal accumulation of fluid in the lung tissue and or the alveoli. Pleural effusion is an abnormal accumulation in the pleural space, which is the space between the lining of the lung and the lining of the chest wall. That fluid buildup in that space could be blood. It could be just normal pleural fluid that is accumulating and building up because perhaps the lymphatics are blocked by a tumor, so they can't drain off the old fluid. Or it might be purulent exudate in the pleural space. How about that one, huh? Or pus in the pleural space, and that term is empyema. Empyema right down here. So that's a favorite of mine. Good one to know. Okay, when we talk about ventilation, we are talking about one complete cycle of inhalation and exhalation. So we may place our patient on mechanical ventilation, a ventilator. We may mechanically ventilate our patient with a bag valve mask. But not only is it important, remember, in the respiratory system to get the oxygen into the system, but we also have to get the CO2 out. So it's inhalation and exhalation. On inhalation, it's a active process. On every breath that we take is controlled by the respiratory center in our brain, the medulla oblongata and the pons. Let's think of how this happens. So at rest, our thoracic cavity has a certain amount of pressure. What do I mean at rest? So inhalation, exhalation, rest. At rest, the pressure that is in my thoracic cavity is actually equal to the atmospheric pressure. So there's no movement of air. But something happens when the respiratory center triggers the contraction of my intercostal muscles, my chest expands, my diaphragm drops, and that expansion of my chest and dropping of the diaphragm, now my thoracic cavity has increased. Because it's increased, the pressure inside has decreased. Now, on inhalation, the pressure in the atmosphere is greater than the pressure in my thoracic cavity. So what happens is that the air is going to rush from the atmosphere down into my lungs. Contrarily, exhalation is not an active process that's controlled by the brain. It's just a rebounding. It is a passive process. So my intercostal muscles relax and my chest returns. My diaphragm comes up and to its normal. So that rebounding is going to compress on the lungs and force air out of the lungs. That becomes a problem since it's a passive process when we have diseased lungs, because we're not able to compress the air out of the lungs, so we have air trapping, and inside that air is carbon dioxide, which we know is toxic and can lead to acidosis. Oxygenation is one of the key roles that the respiratory system is involved with. Oxygenation, however, utilizes two systems of the body. Well, multiple systems, but two primarily for this discussion. Number one, the respiratory system is going to get oxygen into our system. But once it gets into the vasculature, that oxygen has to travel to the tissues and organs of the body. And that's the responsibility, that transport of the cardiovascular system. So we need both healthy respiratory system, and we need a healthy cardiovascular system in order for oxygenation to occur. Oxygen transport. There's two primary ways that oxygen is transported once it gets into the vasculature. The most common that we're most familiar with is that the oxygen is going to bind to the hemoglobin on a red blood cell. So if these are my red blood cells, there are hemoglobin molecules that are on the outside of the red blood cell. Each hemoglobin molecule has 4 receptor sites for the purpose of carrying oxygen. So that's the primary way, is that the oxygen is going to bind to the receptor sites. And we can actually measure the approximate percentage of receptor sites that are available that are bound with oxygen, and that is our O2 saturations monitor. The second way that oxygen is transported in the body is, let's say that this is my vasculature. If this is the vasculature, the oxygen that is not bound over here to the hemoglobin actually dissolves into the plasma. That oxygen is going to dissolve into the blood plasma. And we can also measure that amount of oxygen by doing what we call an ABG. So the ABG, or arterial blood gas, is going to measure the amount of oxygen that has dissolved into the blood plasma. O2 saturations, O2 sats, on the other hand, are going to be measuring the amount of oxygen that is bound to the hemoglobin molecules. Look at this, chemistry. Thought you'd never have chemistry again. Here it is. Oxygen plus hemoglobin equals oxyhemoglobin as a compound. The oxygen hemoglobin dissociation curve is, I don't want you to get all wagged out about that, and even when I show you this graph here, all that we're saying that the oxygen hemoglobin dissociation curve represents is that here's that oxyhemoglobin compound. In order for oxygen to bind to the hemoglobin, the pH level and the CO2 levels and the body's core temperature needs to be at a certain state of homeostasis. If the pH level, CO2 level, and or temperature level gets way outside of the normal range, or what we call homeostasis, that is going to do one of two things. It is either going to prevent oxygen from being able to bind to the hemoglobin molecule, or once that oxygen is transported through the body and gets to the cells and the tissues, it's not going to be able to release from the hemoglobin in order to get into the cells and tissues. So the oxygen hemoglobin dissociation means association is the binding of oxygen to the hemoglobin receptor site. Dissociation is breaking free of the oxygen from the hemoglobin receptor site so that it can feed oxygen to the cells and tissues of the body. That's all that we're saying. So in order for oxygen to freely bind and freely dissociate or release from the hemoglobin, the body needs to be in a state of homeostasis relative to pH levels, temperature levels, CO2 levels, and either way, too high or too low is going to cause a problem one way or the other with that oxygenation process. So the brain, as I mentioned earlier, is going to determine the actual rate, rhythm, and depth of every respiration on every patient. And how does it determine that? Well, it's going to be basically trying to meet all of the body's metabolic demands from a respiratory standpoint. The way in which the brain will determine the rate, rhythm, and depth of respirations is that it is going to analyze data that is being continuously sent to it through chemoreceptors that are strategically placed throughout the body. These chemoreceptors are in the aortic arch, the carotid arteries, excuse me, and then also measuring pH levels in the blood and cerebral spinal fluid. So based upon what data is being sent from those chemoreceptors, the brain will make a determination relative to respiratory rate, effort, etc. for the patient. This is what I want you to know predominantly in this slide. So we said that the respiratory center in the brain determines the rate, rhythm, and depth of respirations. For you and I, of all those of all that data that the brain is getting from the chemoreceptor sites, the most important is the CO2. For you and I and the people that have healthy lungs, the normal stimulus to breathe is going to be based upon our CO2 levels. So we take a breath, we exhale, our CO2 levels are going to rise. And then when our CO2 levels rise, the body sends a signal and we take a breath. The problem is that if we have a patient, for example, that has COPD, chronic obstructive pulmonary disease, there's some of the patients that I mentioned earlier where they have that air trapping because they have diseased lungs. They can force air in, but because if it's a passive process and we have diseased lungs, they get air trapping. And what is trapped in that air is CO2. So for COPD patients, they have chronically high CO2 levels. So the body can no longer determine when that individual needs to take a breath based on their CO2 levels because they're chronically high. So what the respiratory center does is basically shut down that CO2 alarm, and at that point they determine when that COPD patient needs to take the next breath, not based upon their CO2 levels, but now on their O2 levels. So when we have a decrease in oxygen levels as they drop to a certain point, then body sends a signal to take a breath. The respiratory assessment you've all learned. Congratulations on passing that in 102. So let's not forget what you learned and make sure that you're able to apply that to your patients with respiratory issues. These are just some of the diagnostic tests that we'll be looking at. Hemoglobin, we talked about hemoglobin earlier. I want you to know these ranges. These are just broad ranges that I would like you to be able to recognize and apply on a test. So for a hemoglobin level, normal is 12 to 18, and that's a broad range, as I said, probably low female to high male range. So 12 to 18. Hematocrit. What is hematocrit? hematocrit. Hematocrit is a ratio. So if this is the normal circulating blood volume, hematocrit is a ratio between, of this 100% circulating blood volume, what percentage of that blood volume is made up of oxygen? What percentage is made up of oxygen? So of the 100% available oxygen, for example, most of the time between 38 and 54% of that 100% is made up of red blood cells. So that's where we get that 38% to 54%. Pulse oximetry and ABGs, we talked about those in a previous slide. Sputum test. Gotta love sputum. Gotta love sputum. Sputum is a great diagnostic tool for the determining respiratory issues, infections. You use sputum studies for, and when we talk about tuberculosis, the definitive diagnostic procedure or test to determine if a patient has tuberculosis is going to be a sputum culture, believe it or not. So when's the best time? Nursing implications. When's the best time for you to obtain a sputum sample on your patient? Early in the morning. Think about that. The patient's been lying down all evening, or at least a little more supine than normal. And then you sit them up, and then also before they've had anything to eat or drink. Excuse me. And then transport it to the lab as soon as possible to avoid any contamination. Chest x-rays, another wonderful diagnostic tool, and probably the most ordered diagnostic procedure to determine respiratory issues. Chest x-rays can tell you if you have a mass. They can tell you if you have a foreign body, as it says here. It can determine if you have pleural effusion, if you have pericardial effusion, if you have pneumonia, atelectasis, all kinds of things. I'm not really going to talk too much about CAT scan right now, but just know that when we get to pulmonary emboli and its discussion, a spiral CT is the definitive diagnosis for a patient who has a pulmonary emboli. We'll talk all about what that is. All right, and then we have MRIs. And let's talk about this one, a PET scan here. Let's say that a scenario might be that a patient goes in for a routine physical, and the doctor notices that there's some shadowing on the X-ray, looks to be some sort of an abnormal accumulation of cells. They would go to something a little more specific, like perhaps an MRI or a CAT scan, and they would say, yep, there's definitely a tumor there. But the MRI and the CAT scan can't determine whether or not that's a benign or a malignant tumor. A PET scan can, however, so that's the important thing. So a PET scan, because of the way that a PET scan is conducted, it can actually determine whether or not that clumping of cells, that mass of cells, is benign or malignant. The way that it does that is it actually, part of what it uses for the patient is that it has a glucose in it. So when they're watching the injection of glucose, what they'll see is that if this is the mass right here, and this is the vasculature, if they introduce the radiographic material for the PET scan, and it just goes right on by in the vasculature, right by the tumor, then it is benign. Sometimes what you'll see, and particularly they'll see the glucose, and there's a glucose uptake into that malignancy. And the reason is that, believe it or not, malignant tumors actually secrete an enzyme that causes an outgrowth of the vasculature into the malignancy so that it can be fed blood. and glucose. So that's how it can determine that. If it just goes right on by, it is benign. If the actual can denote an uptake of that radioisotope containing glucose into the mass of cells, then we know that it is a malignancy. VQ perfusion scan used to be the go-to standard for determining if a patient has a pulmonary emboli. It's a radioisotope, a nuclear medicine type of test, and it helps to differentiate whether or not your problem is a respiratory problem versus a cardiovascular problem. So most of the time, as I said, in order to definitively diagnose that a patient has a pulmonary emboli, they're going to go to the CAT scan. In the event that the patient has an allergy to the CAT scan contrast, then this is the next go-to, and it also is definitive in its ability to diagnose if the patient has a pulmonary emboli. Thoracentesis is the procedure where a needle is inserted into that that pleural space that we talked about when there's an abnormal accumulation in the pleural space. That's called a pleural effusion. Thoracentesis, the physician can place a needle in that pleural space and draw that fluid out. Not only does it remove the fluid, but also they can then take that fluid and they can analyze it to see exactly what it is. Is it blood? Is it just excess pleural fluid? Is it purulent pus in the pleural space, which we called empyema? Remember, don't forget that, empyema. Let's say from a nursing implication standpoint that your patient has just returned to the unit after undergoing a thoracentesis for a pleural effusion. What will the nurse monitor for? Well, you're going to monitor for complications. Just remember this saying if you can for me. For every intervention, there's a correlating set of potential complications. For every intervention, there's a correlating set of potential complications. For thoracentesis, think about the potential complications. You're sticking a needle into the patient's chest. You're hopefully placing that needle in the pleural space. What happens if you go too far? Well, it actually will puncture the lung, and now you've got a pneumothorax. Now you might not have the fluid accumulating, or it still might be accumulating, but you also have air that is accumulating in that pleural space. Likewise, in introducing a needle like that, you might accidentally hit, vasculature. So when you're monitoring a patient that's returning to the unit after undergoing a thoracentesis, you're going to be looking for, down the road a little bit further infection, but on a more immediate note, you're going to be looking for respiratory compromise and cardiovascular compromise. Endoscopic exams, bronchoscopies, they're excellent tools, diagnostic tools to visualize the airway. They can also remove large mucus plugs. If there's a foreign body, you can use an endoscopic exam for that. You can lavage for determination of whether or not there's some cancerous cells that might be in the airway. But here's what I want you to know about this slide. Look at this. I've got it here and I've got it down here. In order to get a valid study for an endoscopic exam, the patient has to have the gag reflex paralyzed or suppressed. And so that allows them to get a good endoscopic exam without the patient, gagging, etc. But also, it's important for you as a nurse to recognize that when that patient returns to the unit, they are to remain NPO until there is a documented gag reflex. Without a documented gag reflex and the patient is fed, that patient is a high risk for aspiration. All right, as the case with, all diagnostic procedures, education. The patient needs to be able to know what they can anticipate preparatory for the test. What can they expect to be happening during the diagnostic test, and then what can they expect relative to recovery, pain, discomfort, limitations after the test has been completed. Maybe the nurse's responsibility to inform to obtain the signature for an informed consent. Yes, the nurse can obtain the signature, but only after the procedure has been thoroughly explained to the patient and the patient has acknowledged an understanding of everything that the physician or the individual that is doing the test has explained to them. When the patient is returning from your different diagnostic procedures, you're going to be looking at vital signs, signs for allergic reactions, respiratory status, cardiovascular status, etc. So assess, assess, assess. PFTs, pulmonary function tests. PFTs are most often administered by respiratory therapists. But let's talk about a couple of them that I would want you to at least understand. There are a couple here, not many, just three, and I want you to be able to identify what they might be used for. The first one is tidal volume. Very easy. Just think high tide and low tide. Tidal volume is the volume of air in one cycle, one ventilatory cycle. Look at that. That the normal ventilation is going to push about 500 milliliters of air. But look at the capacity, those 300 million alveoli, 6,000 milliliters is the capacity. And with each normal breath, we're only typically using about 500 milliliters, pushing 500 milliliters of air. These two here, important when we talk about COPD. That's the forced vital capacity and the forced expiratory volume over 1 second. Both of these have to do with exhalation. So we are going to use these tests, the pulmonary function tests, to help us to diagnose when our patient has a respiratory disorder, such as COPD. We're going to use pulmonary function tests in order to determine perhaps if the patient's COPD is progressing from where it was a year ago, as an example. We can use our pulmonary function test to determine whether the pharmacologic agents we're giving our patient are actually helping the patient's respiratory status. So we have an improvement in our pulmonary function tests at that point. But these two right here are going to be the measurement to determine for COPD patients whether they have COPD, whether disease is progressing, or whether or not the medications perhaps and medical interventions that we are using on our patient are actually improving their respiratory function. So good to know right here. These two are good to know. Okay, acid-base balance. The body is in a continual state of trying to maintain homeostasis. Homeostasis relative to thermoregulation, homeostasis relative to our patient's fluid and electrolyte volumes. And then another big one is the body's ability to maintain homeostasis relative to the acid-base balance. So we're going to look a little bit about what transpires in that acid-base balance, what components do we need to be able to understand that contribute to tipping the acid-base balance one way or another. And so for purposes of ongoing slides, let's remember that the normal arterial pH of a patient is between 7.35 and 7.45. All right, let's look at this slide here. So we said that the normal pH range is between 7.35 and 7.45. An actual perfect pH would be right here. And that would be perfect would be 7.40. Well, guess what? We're not going to be able to maintain a perfect pH, but the body's been able to maintain its normal metabolic functioning and metabolic processes as long as it can keep its acid in the range between 7.3 pH and 7.45. But once the pH falls below 7.35, it is now in a state of acidosis. Once the body has exceeded 7.45, it is now in a state of alkalosis. So greater than 7.35, the body's in a state of acidosis. When the pH gets above 7.45, the pH it triggers what we call an alkalosis. Either way, pH drops too low in an acidotic state, the patient's going to die. The patient pH rises too high in a state of alkalosis, guess what? The patient is going to die. What contributes primarily to that acid-base balance? Well, when the body undergoes normal metabolic processes, there are two primary waste products of all metabolic processes. That means once the metabolic process has happened, they're going to kick off some compounds. What are they going to kick off? They're going to kick off water and carbon dioxide. So let's just consider them waste products of the metabolic processes. Well, eventually that water and CO2 is going to make its way into the vasculature, into the bloodstream. So you're going to have CO2 and you're going to have H2O in the body's vasculature. And so multiply these over. And what happens though is that I'm going to let you in on a secret, is that CO2 and H2O, they got a thing going on, if you know what I mean. Yeah, they're gonna hook up. They're going to hook up. CO2 and H2O are going to hook up throughout the vasculature. And now no longer do we have CO2 and H2O, but we actually have this chemical compound, which is H2CO3. And H2CO3 is carbonic acid. Carbonic acid is the primary acid component of the acid-base balance. Likewise, in order to balance the carbonic acid, the body is also going to produce and release bicarbonate. Bicarbonate, you remember, was secreted in the amylase, trypsin, and lipase from pancreatic enzymes. Also, the kidneys will produce and will excrete bicarbonate to help in that buffer. This is interesting. How powerful is this carbonic acid? Well, for every one carbonic acid compound, it is going to take 20 bicarb compounds to buffer it. For just every one carbonic acid compounds, it's going to take 20 bicarbonate in order to balance it out. And here's a pictorial of what we just said. CO2 and water are byproducts of metabolic processes, and they have an affinity and attraction towards each other. They hook up and form carbonic acid. And that's the primary acid component in the acid-base balance. Hey, are you ready to learn how to analyze ABGs? Well, that's exactly what we're going to do here. And for the purposes of ABG analysis and for testing purposes, I want you to memorize. This is the pH level we're going to use, 7.35 to 4.5. Don't have to worry about O2 right now. The CO2 levels, 35 to 45, and bicarbonate 22 to 26. And I know that those values may change depending upon your hospital, but for testing purposes, we're going to look at normal range for pH is 7.35 to 7.45, normal CO2 35 to 45, and a normal bicarbonate 22 to 26. All right, let's look at how to interpret ABG results. The best method, the most efficient and the easiest method I've ever seen was developed by a woman named Dr. Linda Valfroio, and she discovered what is called the land of ABGs. I want to explain ABG analysis using the technique that she portrayed in her paper. So let's look at that. So we're going to say that if you look down here, you can see these are our ABG results here. What Dr. Von Frolio says is that every ABG interpretation is going to have a first name, it's going to have a middle name, and it's going to have a last name. Now, the interesting thing about the land of ABGs is the reason she's calling it ABGs is because it seems like everybody's related. There's only, two possible first names, two possible middle names, or two possible last names of everybody that lives in this land of ABGs. Everybody's related. It's like another state that we know of in the United States here. So, no, I'm just kidding. So maybe I better do this just so I'm not upsetting anybody. Okay. Um, so the way that the land of ABG works is that we're going to go ahead and look at the last name first. So just think the last shall be first. And in order to determine what our last name is, we're going to look at the pH level. So if the pH level in our ABG results, if the pH level is between 7.35 and 7.45, it's normal. If, however, the pH is less than 7.35, our last name will be acidosis. If our pH is greater than 7.45, our last name will be alkalosis. So in this situation with a pH of 7.50, it's greater than 7.45, so our last name is alkalosis. The next thing we're going to look at is our first name, and so that's number 2. And again, we're going to look at the pH. Now, there's only one or two possible first names. It's either going to be a first name of compensated or a first name of uncompensated. In order for it to be a first name of compensated, the body must have done just that. They must have compensated and brought the pH back within the normal range of 7.35 to 7.45. If, however, the body has not been able to compensate and bring the pH back to the normal level, then it's going to be a first name of uncompensated. So in this ABG result, is the pH level within normal range? No, 7.5 is outside the normal range. So that's why our our first name is going to be uncompensated. Now that we have the first and last name, all we have to do is decide what is the cause of this alkalosis. What is the cause of the alkalosis? And in order to do that, we're going to look at the CO2 level and the HCO3 or the bicarbonate level and find out which one of those two is out of the normal range. If the CO2 is out of the normal range, then it's a respiratory cause. If the bicarbonate is outside the normal range, it's a metabolic cause. So let's look at these two. The CO2 appears to be in the normal range between 35 and 45. But look at the bicarb. The bicarb is outside the normal range. So our cause is a metabolic cause. So the middle name is metabolic. What is our ABG interpretation? Uncompensated, metabolic, alkalosis. Yes, it's actually really that easy. Let's just do another one here so that we can assure ourselves that it's easy. So the first thing we're going to do is look at the last name. Here's our ABG results right here. First thing we'll do is we'll look at the last name. If the pH level is less than 7.35, our last name is going to be acidosis. If the pH is greater than 7.45, our last name is going to be alkalosis. pH 7.31, well, that's less than 7.35. That gives us a last name of acidosis. Then we're going to look, remember, at the first name next. Again, we're going to look at the pH. If the body's been able to bring the pH within normal limits of 7.35 to 7.45, our first name will be compensated. If the body hasn't and the pH is still outside this normal range here, then the first name will be uncompensated. Well, let's look at our result. pH 7.31, clearly outside the normal range. So our first name is uncompensated. Now we're just going to look, what's the cause? Is it a respiratory cause, in which case the CO2 will still be jacked up, or is it a metabolic cause where the bicarbonate is jacked up? So when we look at these two, a CO2 of 50, that is clearly outside the normal range, and you see that the bicarb is within the normal range. So CO2 is the problem, and our cause is respiratory, so that means our middle name is respiratory. What is this ABG interpretation? Uncompensated respiratory acidosis. And I can throw any of a number of combinations at you in my ABG results and just use that same formula. Last name first, then first name, then middle name to determine the cause, and you're going to get them right. You will see a few of these on each of the tests, on the test number 1, and then also on the final. Remember, the final is going to be comprehensive. So let's look at another one and see what's going on here. Well, the first thing you might notice when you look at the ABG results, which I know you might do first, is that you're going to see something unusual. What are you going to see? That's in the normal range. That's in the normal range. That's in the normal range. So what is the term? What's the analysis when all three are in the normal range? It's a Latin term called normale blood gas. No, it's just normal blood gas. You'll see one of those on the test. So when you see that pH and then get excited and the other two are within normal range, yeah, guess what? It's going to be a normal blood gas is what you're going to determine as your answer. And then I know you type A's are out there saying, well, when are we going to use compensated for our first name? All right. Well, we said we're going to use compensated when the body has been able to bring the pH within the normal level. So look, pH 7.35, normal level. You might get excited thinking it's going to be a normal blood gas, and no, CO2 is outside the normal range, bicarb normal range. So we know that it's going to be compensated. What is the body compensating for? Let's see, can we determine most likely, did the body compensate to bring the pH back into a normal level from a state of acidosis or alkalosis? Well, when we look at this, it is clear that the pH just snuck back into that normal range of 7.35. What was it previous to that? It was an acidosis. It was an acidosis. So our last name is acidosis. So we're going to have a compensated acidosis. And again, what's jacked up here? Well, which of these two are outside the normal range? And we can see that the CO2 is outside the normal range. So it is a middle name of respiratory. So compensated respiratory acidosis. And that's why I just think that the land of ABGs are just so wonderful. So you can take this and you can practice, putting down other ABGs that you might want to use. But I think it's just an excellent system for analyzing ABGs. Hey, listen, this is going to conclude today's session on the respiratory system, and we're going to have more videos to come as we look at upper GI disorders, and then we look at lower GI disorders. So be safe, be strong, and have a great day.